When we first met back in December, we were very high level at looking at how will we develop or design this enhanced care coordination model for the behavioral health population. So we started looking at some preliminary data. This is just a reminder of what we hope to accomplish once the health homes model is designed and implemented. These two goals are first and foremost as we make sure the services we provide in terms of that enhanced care coordination meet the needs of the individuals who would be eligible for those services. Let me take a quick step back. Wanted to make sure that everyone understands when we talk about a health homes model, it was a provision born out of the Affordable Care Act of 2010 that allows states the option of incorporating as a part of their state Medicaid plan an enhanced care coordination component for individuals who have either chronic conditions, are at risk of developing a chronic condition, or specific to the behavioral health population, individuals that have a serious and persistent mental illness. CMS, the oversight entity for health homes, it's largely left it up to the states to define who would most benefit from enhanced care coordination. We think that's a benefit in that they are not being as prescriptive as they've been in other instances with new initiatives. So it really gives states the option of tailoring a care coordination program specifically to the target population for that particular state, the makeup of the individuals that receive behavioral health services. This particular slide we have been using not just for behavioral health, but as many of you may be aware, there are health home models being developed for our developmental disabilities population as well for our elderly population, either those receiving services in a home and community-based setting or those in a long-term care setting. So we have 3 different health home development initiatives happening simultaneously, and these are the guiding principles that will span across those populations. This is one of our favorite slides, just to remind everyone what a health home is and what it is not. We know it's a confusing term, so we just like to make sure when we're talking about enhanced care coordination that everyone is on the same page as to what we're talking about in terms of a behavioral health home. Anyone who has heard this spiel 1,000 times know that this is probably my favorite slide. I've classified this as our blueprint or our guidepost or our map that will help us stay on target in making sure that we live up to the guidance that CMS has put out about the service components that must be included in a state's health home model. And so upon planning, moving forward, development efforts, receiving feedback from stakeholders, we have to ensure that we are at some point checking off all of these service components. So hopefully once we've finished with all of these planning efforts, we will have a wonderful enhanced care coordination model for the individuals that we serve. If you will recall last time, we talked quite a bit about the first bullet point on this page. We started at the high level 50,000 foot view of, okay, how do we start to hone in or refine who would be eligible for a behavioral health home. So we spent quite a bit of time last time discussing some of the approaches we will use to determine who will be eligible. We talked about looking at utilization data and identifying those with what we call those high-level needs. That's one approach we will use. The second approach we will use is what we're calling a comprehensive assessment to help us hone in on the functional needs. And one of the important things I think we need to keep in the fore when we talk about how informative that comprehensive assessment will be, one of the components of the health homes, as stated by CMS, should be what they're calling preventative or wellness health promotion component. We're from the mindset with our healthcare system of taking care of issues after they've presented themselves and being in that reactive mode. Hopefully with health homes and the promotional health education and wellness component, by utilizing that comprehensive assessment, we're hoping with the identification of those risk factors that we will be able to really come in and do a proactive type approach in preventing some issues from either escalating to higher need levels, or maybe, if all the stars align, even preventing some issues from becoming prevalent or prominent. So today, if you look here, we have 2 bullet points, and we get excited when, after all of the feedback and input that we've received from stakeholder groups, when we come out and talk about what we're hoping to accomplish, or what we hope the outcomes to be from a Health Homes program or services, we've talked about those 2 goals. So we've overlaid the 2 goals of the behavioral health home, one providing the care coordination. And beneath that bullet, you'll see what I call activities categories. Those are not the health homes activities in and of itself, but what this will do is help us kind of flesh out what those health home services will look like. And that second bullet, you'll see another huge component or goal of the Health Homes program is to manage the core care delivery. And if you would remember, the way we classified that, those are the direct behavioral health services that an individual would receive. So a care coordinator would really have a variety of health homes activities that would be rendered. One thing I want you to remember is that we've talked about this being very much person-centered. So those health homes activities may look very differently for one individual than they would for another, but there's some services that a health home or care coordinator will provide on what we call a population-based level, and we'll talk about that in a few. You can tell we are so proud of this slide. We stick it in and show this any opportunity we can share this. The reason we included it here, most of you who have participated in smaller stakeholder groups, or those of you that have that participated in the previous December public work group, this is really more specific to how the behavioral health system of care, future behavioral health system of care, is envisioned. The reason we have it here, we want to make sure that we point out 2 things. In the future, every Medicaid beneficiary would receive some type of care coordination. The majority of individuals will receive that care coordination through what we're calling a patient-centered medical home. That's another development initiative that's being planned and underway right now. In a patient-centered medical home, there's tons of information out there, but it's basically a team-based approach to providing medical care that's largely led by a primary care physician, a PCP, family doctor, a pediatrician, or the like. The reason we wanted to include this slide here is to show the different levels of care coordination that could be received. If you look at the far left box, those are the individuals that have that lower acuity or lower need level, and they would not require the more intensive enhanced care coordination through a health home. Same for the individuals on the top right box. But the reason we wanted to show this, for those individuals with those high needs that we talked about, or the findings that come from that comprehensive assessment, you would see some individuals may require more intensive care coordination, and that would be provided through a health home with some correlation or linkage to the patient-centered medical home, and we have some slides that we'll share a bit later. On this particular slide, what we wanted to show, there again in a very high level, is what the relationship would look like between all the players or involved parties. And we also thought it was important, rather just to include, here's the health home, it's person-centered by showing the individual and family there with all of the services and resources surrounding and supporting them, but we thought it was important to include some general responsibilities of each of those entities. And we'll start with the health home, seeing that that's what we're basically talking about today. We talked about what the primary responsibilities would include: managing the core care delivery, also providing the care coordination. And again, I will reiterate that it's not just the care coordination for behavioral health services. It must span that full continuum, any need that the individual or family would present. So whether that's community-based services and supports, medical in nature, so that's where you can see there would be some coordination or linkage with the patient-centered medical home or the primary care provider. The other thing I wanted to mention, we don't have listed on here, and we may consider including it. Oftentimes, there's some confusion about who's responsible for what. And when we talk about the patient-centered medical home having some care coordination responsibilities, and that being the primary function of the health home, one thing that we probably will want to include is who's responsible for what in terms of care planning. For the health home, the care coordinator would be responsible for the integrated care plan. And as we go down to the bottom left corner, the behavioral health provider, of course, would be responsible providing those direct care behavioral health services we talked about. But that entity or person would also be responsible for developing the behavioral health treatment plan. Moving on over to the patient-centered medical home and the extended team, the PCP or the family doctor would be responsible for coordinating any medical services that are needed by that individual. And you can see where there would be some interplay or overlap in what the health home or care coordinator would be responsible for. But the primary responsibility for coordinating medical services will lie with the patient-centered medical home provider. With that said, the care plan responsibility for medical services would lie with that PCMH. And last but most importantly, not least, is the individual. We think it's important to note here that the individual and family is not only responsible, they're not only responsible for receiving services, but they have really an active participatory role that they should play in the healthcare delivery system as well. And so it's not just that we want to defer or insist that they have an active participation, but one of the three goals from CMS is to ensure that patient satisfaction or engagement is improved. Now, for you clinicians or providers, you know that's more than a mouthful. Our challenge will be coming up with ways to motivate, and don't like to use the word incentivize because usually we think of that in terms of reimbursement, but really how do you incentivize a person to take more of a participatory role in the delivery of their health care? How do you get them to be more vested in the process? So we've had several clinical advisory group meetings, and that is one of the primary concerns or feedback that we hear as a primary concern from clinicians is how do you make that happen? So we will all be challenged to come up with ways to ensure that that happens. It will be no small task. As we move into talking more in detail about what health homes activities could or should look like, we thought it was a great opportunity to overlay what the current system looks like in comparison to what role the health home or care coordinator will play in the new system we're envisioning with that enhanced care coordination. What I think is important to note here, the way the schematics of this slide, it's laid out to show what happens procedure or service-wise along that full pathway from when a person is from intake, when a screening is completed or an assessment is done. You can see the correlating CPT codes that are currently billed as a part of today's system. And then as you move into treatment using that recovery-oriented approach throughout the treatment process, you can see what some of the current system CPT codes are that are billed today. The one thing that I'd like to point out, you can see on the bottom section of this page, when care coordination is inserted into this system of care, you can see that it would really support the other efforts that are happening on the direct care behavioral health service side. And we just wanted to show, we thought this was a perfect opportunity. We think in terms of flipping a switch from old system to new system, when really a lot of times there's a perfect interplay that takes place when you involve a new initiative, especially in terms of behavioral health where largely case management or care coordination has been lacking. So we're really excited about this opportunity to insert care coordination as a part of the behavioral health system of care.